It's a pleasure to be here today. I really appreciate your time, and it's certainly an honor to speak before you. So today we're going to be talking about a variety of aspects of cannabis use. So the title of the presentation, obviously, the blunt truth, and looking and exploring the social, legal, and neurodevelopmental impacts of cannabis use. So here are my disclosures. I did receive an honorarium for being here to speak with you all today, and I very much appreciate that. Thank you, CCJC. All of that money will be donated directly to the Denver Health Foundation, where we will be using those funds to further research and treatment of adolescent and young adult substance use and mental health disorders. So, objectives for today, we're going to be reviewing the history and background of the cannabis plant itself, and we'll be assessing the effects of cannabis use not only on the mind but on the body from a neurodevelopmental perspective, thinking about the acute effects of cannabis use as well as the longer term, more longitudinal effects over time. We will also be reviewing the history of cannabis regulation in the United States as well as here in Colorado, and then moving on to explore the impact of academic performance. And I have stats and data specifically here in Colorado for youth who are using. And then we will also review evidence-based treatment modalities very briefly, thinking about options for treatment and care. So a little bit of history to begin. So cannabis has been around for quite some time, as I'm sure that you're well aware. For many millennia, actually. The plant itself originates from Central and Southeast Asia, and there are a variety of different strains, sativa, indica, and ruderalis. Ruderalis is especially important for hybridization, thinking about ways to increase potency, which we're seeing very much of here in Colorado, and we'll talk about that more in a bit. There are also a variety of different preparations. So cannabis is the plant itself, and under that umbrella of terms are a variety of different means to prepare and then consume the product. And then we'll also be talking again about the effects, both acute and chronic. So you'll oftentimes hear me refer to THC throughout this talk, or delta-9 tetrahydrocannabinol, which is one of the many. There's roughly 70 plus psychoactive compounds that are present within cannabis. This is one of the many compounds, and this has quite an effect on the brain itself, a lot of the psychoactive effects. You also hear me talk about, at points, CBD or cannabidiol, and I'm certainly happy to talk about its effects, and certainly we'll have time for questions and discussion after a bit here, which I hope that we have a lively discussion, and I'd love to get your perspective about what you're hearing and seeing in the media, as well as what you're seeing day to day in your practice and work. So yeah, I hope that we have a great discussion. So let's move right into it. So the strains themselves, really, sativa is the strain that we see that is very highly concentrated in THC versus CBD. It's important to note here, I'll just take a moment, that CBD itself does not really have much, if any, of the psychoactive or euphoric effects that we see commonly with THC. So sativa, higher concentration of THC, and typically tends to be more energizing and creates a euphoric effect in users. And again, much more of an effect of the mind over the body here. Contrast that with indica, cannabis indica, we typically see much more concentration here of CBD versus THC. And this strain typically tends to be quite sedating on individuals and does not have the higher euphoric effect typically. But again, there is certainly THC present within cannabis indica, just lesser of a concentration. And then ruderalis, as I mentioned previously, is primarily used for hybridization purposes. So the variety of different preparations. So marijuana itself refers to the dried leaves or buds of the cannabis plant, and that's what we see right here. Kief are the small powdery particulations that come from the flowers and the buds, and when the plant is ground up, this could be extracted and used to be packed in a powdery cake formulation or sprinkled on. Users will oftentimes sprinkle this onto marijuana itself in order to increase potency. It's highly potent. Hash, we typically see, this is a hash bar right here, but we also see that from hash, oftentimes is the oil that will be extracted from the plant, which again is highly concentrated and quite potent with THC in many cases. So some common street names, oil, this is butane hash oil, which is extracted through a very arduous and pretty dangerous process that is not certainly by any means the same process, but similar in many ways to the process of making meth, actually. So using a highly volatile solvent, butane, the THC oil here is extracted to create a highly, highly potent formulation. There's also shatter, dabs, and wax are other common street terms for oil, which comes from hash oil. Tincture is also another formulation where THC primarily is extracted into a liquid formulation, and it can be added then to different, edible goods or products, including teas. So tincture is one, and then canna butter, highly potent oil here as well, that oftentimes is flavorless and does not have a specific smell or color to it. This has been dyed to add for color. So just to give you a general sense, relative concentrations of THC, this is per the United Nations Office on Drugs and Crime from 2009. So this is the framework that we had been working with for many, many years and thinking about relative potency of different formulations of cannabis. What I can say is that especially here with marijuana in Colorado in particular, we're seeing that this number has doubled, if not tripled at times, based off of different hybridization techniques that grow factories are using in order to increase and create highly, highly potent marijuana. And we'll talk here in just a moment about the effects of that increased potency. So acute effects, we typically see that individuals using will have redness of their eyes and that their mouth will typically become dry when using especially the smoked formulation. Skin typically becomes either hot or cold, and that's the way in which the compounds and ingredients interact with our nervous system and stimulate different receptors within the skin and within our vascular system. Also, the heart, typically we see tachycardia or an increased heart rate, especially in adults, and there are certain implications for this that we'll talk about here in just a bit about another dangerous effect that's secondary to this increased heart rate. And then skeletal muscles typically become relaxed after using. Here is a cross-section of a brain, and this comes from Wilson Compton and colleagues, Associate Director of the National Institute on Drug Abuse in Washington. So what they've done here is given you a cross-section of the brain and highlighted in different colors the specific areas and the function of those areas. So right here we have the prefrontal cortex, which is highly involved with executive functioning, higher level decision making. And then this is part of the motor cortex here in green, which is involved with movement. This part of the cortex here, the neocortex, is involved with sensation. We have the occipital cortex, which is involved with vision. The cerebellum right here in red, which is involved with coordination and movement tasks. Also, we have the hippocampus here, which is highly involved with imprinting memories and short-term memory making. And then the amygdala, which is highly involved with the reward pathway. So what we see, again, cross-section of the brain, highlighted functional domains, and then these yellow dots give a relative concentration of endocannabinoid receptors. Cannabinoid receptors are naturally occurring receptors in all of our brains, in all of our nervous systems. And actually, they're present throughout a variety of other systems within all of our bodies. So what we see here then is that the prefrontal cortex, again, highly involved with higher level decision making, has a vast concentration of these endocannabinoid receptors. So we know that individuals using cannabis will be certainly impaired from an executive functioning standpoint, and physiologically that really makes sense. We also see that these individuals will have alterations in their function with regard to movement and sensation, in addition to coordination here through the cerebellum. Vision, we don't really see much of an impact or an effect, and that makes sense as well physiologically. Hippocampus and our reward pathways here through the amygdala also have these receptors and then will, of course, be affected as well. We also know, as a side point, that the endocannabinoid system and these receptors are highly involved with normal brain development, okay? And that overstimulation, or at times even stimulation at all, can actually set off a cascade of mechanisms that can occur that can dysregulate the normal developmental process of the brain and the nervous system. We also know that the appetite center within our brainstem has these receptors, and it can be affected by use. We also know that immunological function is also affected quite greatly in certain individuals because of the fact that our white blood cells, which are involved with fighting infection and involved with cancer, right, that they also have these cannabinoid receptors on them. Excuse me. Our reproductive systems in both males and females also can become dysregulated and affected by use, and then the pain regulation system also as well. So right now, we're going to move into kind of thinking about what does acute exposure do to an individual at various developmental time points, and then we'll also correlate and kind of bring this back full circle and thinking about what does earlier exposure potentially set an individual up for later on, right? So beginning in utero, when a fetus is developing, we know that mothers using cannabis, regardless of the formulation, that roughly a third of the THC that's consumed will cross the placenta and then be exposed to the developing fetus. We see quite commonly that fetal oxygen delivery is also affected, in many ways quite similar to that of tobacco smoking. And we also see, again, these endocannabinoid systems, a lot of these innate systems that are involved with cell development, migration, normal development are all affected. And this is actually work from Nora Volkov, who is the director of the National Institutes on Drug Abuse, NIDA, under the NIH, and we're seeing this very clearly. We also see Dr. Paula Riggs here at the University of Colorado has also taken away from research that's been coming out of the CDC as well as other research groups and noticing pretty significant and concerning similarities between exposure to cannabis in utero to exposure to small doses of lead and lead toxicity, which we hear a lot about. So a direct effect, no, but certainly very similar effects in some ways, so something to be mindful of. We see that individuals who are exposed to cannabis in utero, on average, will have a decrease in their IQ by 5 points by the time that they're 6 years of age. And just to kind of give reference, these are all references to where these stats are coming from the medical literature. We also see that these individuals, when exposed in utero, will have an increased risk for depression, be more hyperactive, impulsive, have issues with inattention, right? And also, and this is a really important point that we'll come back to, individuals exposed here in utero also have an increased risk and odds of using later on in life, especially during adolescence, but not only using, but using more heavily than their peers and cohort who had not been exposed earlier on. And
the IQ points, is that just based off of an average for that age, or how are you determining the 5-point loss?
So what we've done is Goldschmidt and colleagues actually, and I'm certainly happy to answer more questions at the end if you don't mind, but these individuals have actually tracked groups and tried to control for as many factors as possible and really narrow down and limit in utero cannabis exposure in a certain group of individuals compared to other individuals with very similar controlled variables who were not exposed. Yeah, that's a great question. So we also see that these individuals have decreased achievement on achievement testing throughout elementary and then moving into high school as well. In infancy, we're seeing that these individuals, there's, kind of the overlay and overlap between moving from in utero to then birth and infancy. These individuals typically have lower birth weight, can be born prematurely, and have poor sleep and poor self-regulation, and also have an increased risk for sudden infant death syndrome, or SIDS. And it doesn't stop there, so we know that THC especially, and as well as many of the other psychoactive ingredients in cannabis, are highly lipophilic, meaning that they have a propensity to really want to be stored in fat molecules. And we know that breast milk is highly concentrated in fat. So roughly half of the THC that a mother consumes will then be transferred in breast milk onto her infant. And we're seeing also that secondhand exposure. In the case here, this is coming from Zarfin and colleagues. This is out of Israel. We also have data that's coming right here out of Colorado from Dr. Sam Wang at Children's Hospital Colorado with very similar case reports, where secondhand exposure in this case, being exposed to smoke from adults and individuals in the home who were smoking cannabis, that there was a 13-month-old who was admitted to the hospital and after an extensive workup was deemed, after all other factors were ruled out, that really that this individual had an inflammatory reaction, it was quite lethargic and non-responsive, developed a temperature. This was all secondary to cannabis exposure secondhand through the smoke. And, especially when we think about kids, crawling around, getting into things within the house, it's also really concerning for not only children, but adolescents and adults, and thinking about how edibles, especially here in Colorado, are being marketed, and that playing off of a lot of very similar marketing to commonplace goods that we'd see in stores and in our homes. So these are Pop-Tarts, but actually highly concentrated edibles. Fizzy drinks, marketing seems to be very targeted in many ways toward youth. And then also cereal bars, once taken out of the package, you could not smell or see really any difference from that of a normal cereal bar that you maybe made at home or had bought from the store. So inadvertent exposures and ingestions are certainly a concern of ours, and we're seeing that over time that there are more inadvertent exposures and ingestions. So again, this is the data from Dr. Sam Wang, which was published in the Journal of the American Medical Association Pediatrics in 2013. So what he saw here is that prior to commercialization and de facto legalization of marijuana here in Colorado, that there were no noted admissions after really careful chart review of individuals, of youth to the hospital, but that after that time, so from 2009 to 2011, we saw that infants and 12-year-olds, that there were 15 hospital admissions, that after extensive workup, chart review of other factors, that they were observed or admitted, in some cases even to the intensive care unit, secondary to direct and inadvertent exposure to cannabis. So thinking about what does exposure during adolescence, what does that do to these individuals? So we know that 1 in 6 adolescents who use cannabis for the first time will go on to develop an addiction. And contrary to popular belief, you can certainly become addicted to cannabis. We see it every day in our clinical practice, and we certainly see it well documented within the medical peer-reviewed literature. So by addiction, I mean that these individuals are needing to use more and more of a substance in order to get the same high or the same effect, and that they will actually develop withdrawal symptoms if they're using consistently and heavily enough. If they go for a lapse in time and are not using, that these individuals will oftentimes engage in risky behaviors, right, in order to acquire the substance or to use the substance. So 1 in 6 after first-time use can go on to develop an addiction in adolescence. We see here, through more chronic, heavier use during adolescence, that yields, on average, a decrease in IQ by 8 points during adolescence. So going back to the previous slide that I mentioned from in utero, right, those individuals had, on average, a 5-point decrease in IQ when exposed in utero. And that we also saw that those individuals were not only more likely to use, but to use more heavily during adolescence. So it's not hard to imagine how an individual who is exposed in utero may go on to not only use, but to use more heavily in adolescence and have a combined potential decrease in IQ of roughly 13 points, right? So that's approaching 1 standard deviation drop in IQ, which is 15 points, all from merely being exposed to or using cannabis. We also see that individuals, especially during this age, and this is a very volatile age when it comes to not only social issues, but also brain development, right? There's a lot that's going on. And so we know that these individuals are at a twofold increased risk of developing a psychotic disorder. And we know that oftentimes those individuals who maybe have genetic loading or maybe more predisposed with regard to family history to psychosis, that they're going to be at increased risk, but certainly anyone, but primarily those with a propensity for psychosis have that increased risk. We also see that there's a doubling in odds of developing an anxiety disorder through use during adolescence. So cannabis use by age 15, again in adolescence, we see that these individuals are on average over 3.5 times less likely to graduate from high school and are 2.3 times less likely to go on and enroll in a college or university program, and that on average they are 3.7 times less likely to actually go on and obtain that college or university degree compared to non-using peers. We also see that there are huge public health issues and concerns. So we see that individuals who use cannabis, especially in adolescence, that they are 50% less likely to actually use a condom when engaging in sexual activity, and so increased risk for unintended pregnancies, right? But also the transmission of STDs, sexually transmitted diseases or infections, right? So certainly twofold risk there. We also see, and this is contrary to a lot of what we hear in the media, but that there is an increased risk for aggression with certain strains and potency cannabis. And this was a study that actually primarily looked at females, is where they saw more of an aggression risk, and it's not really clear as to why, but certainly a potential increased risk for aggression as well. And then the last point here, this really is referring to the gateway drug hypothesis, which we've heard for so long, but we are seeing very clearly, decade over decade, that that's true, and then certainly here in Colorado too. So we know that these individuals who are using cannabis typically don't just use cannabis, and that oftentimes, sadly, they will go on and convert to other substances, and when they do, they typically tend to be pretty heavy, hard substances like abusing prescription opiates, converting and using and abusing IV heroin, right? Cocaine. And that's, the exact mechanism as far as why, and being able to target and say who's at an increased risk is still not exactly clear, and that's part of the research that we're doing right now and trying to better understand this process. But certainly we see it very true, very clearly in the literature that, again, increased risk for going on to abuse other and harder substances. And it makes sense physiologically and developmentally, right, that adolescents really are a very vulnerable population just based off of their neuroanatomy, physiology, and development. So what we have here is based off of work from Casey and colleagues looking at normal neurodevelopment. And so we have age here and then functional development of the brain. And then we're looking primarily at two different systems. The prefrontal system, again, higher level executive decision making, compared to the brain reward circuitry, the circuitry that's really aimed at trying to satisfy needs, and especially trying to satisfy goals or attend to drives right in the here and now. And so what we see is that here, this is adolescence, right, that the prefrontal system, its development, far lags behind that of the brain reward circuitry, right? So we see that there's a huge gap right here, and that adolescents really in particular, and young adults, but adolescents in particular, are really hardwired to satisfy needs and drives now. So act first, think later. And that's a major takeaway developmentally. And actually this research is not necessarily focused on substance use here, just looking at normal neurodevelopment. And it's easier than ever, right, to be able to use and abuse cannabis in particular because of different formulations and different gadgets that allow you to use cannabis. So this is primarily going to be for, this is a vape pen, and so being able to pretty discreetly use with a little burst of fairly odorless vapor that comes out. This is an asthma inhaler that's been outfitted with a heating element that allows the individual to heat the oil and consume pretty discreetly. These are highlighters where the back pops off and you have a pipe here, so smoke a bowl, tuck it back in, throw it back in your backpack, no big deal, pretty discreet, wouldn't be able to tell just by glancing. So I'm going to take a break just for a short moment and listen to Dr. Christian Thurstone, one of my mentors here, talking about, this video came out prior to Amendment 64 being passed, but really talking about the unintended social consequences of legalizing a substance and despite the fact that clearly Amendment 64, when you look at how it was written, it was not intended necessarily for legalized recreational use for adolescents, right? But we know and we see very clearly, we've seen it with tobacco, we've seen it with alcohol, we're seeing it unfortunately with cannabis as well, that there's unintended consequence when you increase the availability of a substance and normalize behaviors and seemingly send the message to youth that it's okay to use, that there are certainly unintended consequences. So we'll listen now.
I am never getting married. Never. Guaranteed.
Sorry about this. Okay, here we go.
When we compared those knowing someone with a medical marijuana license to those not knowing someone with a medical marijuana license, those knowing reported more favorable attitudes, opinions, availability, less perceived harmfulness about marijuana, more frequent marijuana use. We see kids every day who are extremely addicted to marijuana. They are dropping out of life about this. They are dropping out of school, out of their families, and they are very addicted and cannot stop. So we know that when you have something widely available, legalized like this, it's very difficult to keep it out of the hands of kids, and it really costs society a lot. Middle schoolers are exactly the age group we'd expect to be most affected by changing norms and customs around marijuana use. Why? Because they're in this concrete stage of moral development where they take their guidance about what's right and wrong from the rules, the clear kind of black and white rules like that. So that's the age group most affected. 60% of all new users of marijuana are kids, right? And we know that kids are especially vulnerable to the detrimental effects of marijuana exposure because of their developing adolescent brain. So adolescents who are exposed to marijuana have a greater drop in IQ from age 13 to 38 compared to those not exposed, up to 8 points. Adolescent exposure to marijuana confers a greater risk of developing psychosis in young adulthood. I would encourage people to think when they vote about this, when they go to the polls, what's good for kids?
So again, regardless of your viewpoint or standpoint on Amendment 64, just something to think about with regard to unintended consequences of legalization of a substance. Moving on, I'm going to talk about what do we see with acute and chronic exposure to cannabis during adulthood. So we know that adults, anywhere between 1 in 9 to 1 in 11, will go on to develop an addiction, compared to, again, 1 in 6 for adolescents. We see that adults using are at a 4 times increased risk of developing an MI or a myocardial infarction, a heart attack, increased risk for heart attack within the hour after using cannabis. And we see that, as I showed in the graphic earlier, because of increased heart rate or tachycardia. So increased risk for heart attack in adults. We also see doubling of risk for bronchitis, chronic cough, wheezing, so especially those individuals who already have respiratory issues are certainly potentially going to experience exacerbated symptoms, and then certainly a risk for a whole host of different cancers. Exactly why, it's not entirely clear, but likely, again, related to the endocannabinoid system and that dysregulation that we see with white blood cells and other mechanisms within our immune system to fight off infection and cancers. So chronic use, this is newer data that's coming out. What we're seeing in adults is that, and it's not entirely clear why in adults versus other age groups, but that these individuals with more chronic, heavier use actually we're seeing more consistently in the literature and anecdotally and clinically that these individuals are developing sustained impairment that can last up to a month after being abstinent entirely. So having more and more issues with executive functioning, cognition, memory, right, that they are not stopping use and then bouncing right back in the way that maybe younger individuals are. And certainly we don't know entirely, could this be happening with youth and that we're just not picking up on it or totally understanding it? It's potential, but we're not seeing it, at least as of this time, to the same degree that we're seeing it in adults. And that there's psychomotor impairment, so again, that process of involving and planning motor movement, that's also affected for up to 3 weeks. We are seeing, luckily it's a smaller group of individuals, but there is a group that we're concerned that these issues or symptoms are not quite ever resolving entirely back to the individual's baseline, even when they've stopped and remain abstinent from cannabis. So certainly more work to be done here to better understand this process. And then we also see decreased fertility in both males and females for a variety of different reasons and mechanisms from cannabis use. So I'm going to speak now a bit about car crash data. This is specifically looking at data that has been coming out of the US in addition to Israel and France. And then I've got more specific Colorado data here just in a bit about car crashes. But we see that individuals who had THC in their bloodstream, right, at or around 1 nanogram per milliliter. A little bit of reference, Amendment 64 established the DUID, the driving under the influence of a drug, that limit was 5 nanograms per milliliter or above. So at 1 nanogram, we see that individuals are 2.5 times more likely to be involved in a car crash, and then over 3 times more likely to be involved in a fatal car crash. And so thinking about not only the risk that those individuals are putting themselves in when they're using, but also everyone else out on the road, right, including youth. And then when we bump that number up to 5 nanograms per milliliter, we see that individuals are anywhere between over 4.5 to over 6.5 times more likely to be involved in a fatal car crash when they are under the influence of a substance. And keep in mind, too, that cannabis sticks around for a while after using up to 30 days. And so certainly potential implications later on. Exactly to what degree, we still don't know yet. And so, I'm very pro-research more than anything else. I'm not trying to sit here and sell you on being, pro or anti-marijuana, but more than anything, I'm trying to send the message that we need more research and more data, but that we also need to acknowledge and look at the facts of what we're seeing already. So just trying to get a better understanding more than anything of the effects, both acute and long-term, from use. So we'll go quickly through the history of regulation of cannabis in the US. Really started with the Pure Food and Drug Act of 1906, where for the first time we saw that there were restricted sales of narcotics under which cannabis was included. So cannabis is still legal in the US at this time, but now requires a prescription from a doctor, and it needs to be dispensed from a pharmacy. And then again, internationally, we're seeing kind of increased regulation, looking at importation, exportation of hemp, and then also more tightly monitored importation, exportation within the US and then other countries as well. Then we have the Uniform State Narcotic Act of 1925, again, increased regulation and monitoring. Federal Bureau of Narcotics, which essentially was a precursor to modern-day DEA in many ways, was founded to provide, again, greater oversight, regulation, and control of cannabis and other controlled substances, but cannabis is still legal. Then we see, again, internationally in 1936, the Geneva Trafficking Conventions looking and aiming actually here to criminalize the use or possession of cannabis for all non-medical, non-scientific purposes. And then in 1937, we see the Marijuana Tax Act, and what that essentially did is made cannabis illegal throughout the U.S. in all states under federal law for all non-medical, non-research purposes. So what we see here is that after 1937, moving into the 50s, 60s, is that the pendulum really swings the other way, where before cannabis was legal, now it's illegal, and there are very harsh fines, penalties, punishment for first-time use and possession, right? And so what we see here is mandatory sentencing in 52, 1956. Again, first-time possession, prison for 2 to 10 years. and being fined up to $20,000 US, and this is again in 1956 for first-time possession. So again, pendulum has really swung the other way. And then what we see is that, challenges to the Supreme Court, looking at, whether or not this should be illegal, really leads then in the 1970s to the beginning of decriminalization. And that we see that Oregon in 1973 was the first to decriminalize the possession and use of this substance, followed by a host of other states during that decade. And then really the era of, quote unquote, medical marijuana. And I say that because I'm happy to discuss more about really, the current literature. When we look at all of the data, there was a really great meta-analysis that came out in the Journal of the American Medical Association last year, looking at, really when we lay out the facts, when we look at the raw data, for better or for worse, what is there as far as a medical indication, and really what we see is that there's moderate, not weak and certainly not strong, but moderate evidence to support the use of certain strains of cannabis for chronic pain as well as spasticity, and that's typically going to be characterized under the umbrella of different motor issues, typically associated with multiple sclerosis or other issues with spasticity. So those are the two indications, and the only two indications where we're seeing potentially moderate evidence to support the use of cannabis. Everything else, you name it, it's not there. It's really not there. And normally, in order to be passed by FDA guidelines, right, we wouldn't accept just moderate evidence. We'd want to see very strong, profound, clear evidence in any group that we're trying to treat. So medical marijuana, 1996, California legalized the use of medical marijuana, as well as, over the coming years, a host of other states. Actually, New York is here in 2014 as well, Colorado in 2000 through Amendment 20. And now what we see is that there are currently 27 states, as well as the District of Columbia here in the US, that have decriminalized the use or possession in some form of marijuana. There are 4 states, Colorado, Washington, Oregon, as well as Alaska, who have legalized the recreational use of cannabis, and Washington, D.C. has as well. So a growing trend. Just a quick quote from Wilson Compton, again at NIDA, looking at and trying to think about maybe the different implications or reasons why we're seeing now the pendulum swing the other way, and that it seems to be a lot of acceptance or curiosity throughout the U.S. about cannabis and why we're seeing that. So looking at the history of regulation here in Colorado, we see that, again, Amendment 20, November of 2000, allowed for the use of marijuana for medical, quote-unquote, medical purposes. That was pretty loosely defined, and during this period of time, the standards and the criteria for receiving a red card, which we see here, again, poorly defined, not really clear as far as kind of what the indications were, and then the cutoff for different individuals. And what we see then in 2009 is that there's essentially de facto legalization. And that really comes from the fact that there was minimal restriction on eligibility, again, for a red card, and that we see that there's a huge increase in the number of medical marijuana patients, quote-unquote patients, during this time because of that. Also an increase in dispensaries during this time. And right around this time, the Ogden memo from the federal government basically stated that, it was a low priority of the U.S. federal government to go after and prosecute individuals who had, who were using or possessing marijuana if they were doing so under the guidelines or the statutes of their states, right? And then during this time, we see that the Colorado Board of Health really fails to reach a consensus on the regulation of the number of patients that a quote-unquote caregiver or provider can have. We also see that, through Senate Bill 109, that, Colorado is really trying to beef up the standards as far as kind of how do you establish and define a bona fide, physician-patient relationship? What goes into a thorough evaluation? You would think that it should be held to the same standards as all other indications for medical evaluation, meaning that you actually meet with your provider, which was not necessarily required before, and that a thorough history and physical examination be done, as well as any other lab testing or diagnostic testing be done in order to confirm or rule out a diagnosis. None of this was required, and is still pretty loose in some ways. And then what we see is then again, November 2012, Amendment 64 was passed, which allowed for the legalized use of recreational cannabis for any adult 21 years of age or older. Obviously don't have to be a Colorado resident. Also allowed for individuals to possess 6 plants, 3 mature, 3 immature, as long as kept in a locked space, and could also possess up to an ounce of cannabis in public. Whereas Amendment 20 for medical marijuana allowed for up to 2 ounces in public for anyone with a red card. And then that DUID limit, again, was established somewhat arbitrarily at or above 5 nanograms per milliliter. And a lot of the rationale behind this comes from a lot of alcohol literature and data and modeling off after alcohol. But we know clearly that cannabis is not alcohol, right? And that the way that it is metabolized and stored in the body and affects different systems within the body, although similar in some ways, is also quite different in many other ways. So thinking about go live, January 1st, 2014, where the first recreational shops were opened. And then since that time, a lot's been going on. Going to kind of go quickly over this, just different types of business licenses for medical marijuana and recreational marijuana. The key thing there is that, the reality is that I think that this is a good step in some ways to try to regulate and to monitor, but overall the standards are pretty loose and certainly not held to standards of, the FDA that we'd see, with food processing or other standards. So youth cannabis use. This is the most recent data that we have coming from both Colorado as well as federal research, and we see that for youth, this is specifically referring to 12 to 17-year-olds, so past month use as recently as 2013, 2014, we see that the national average was 7.22% compared to the Colorado average for youth 12 to 17-year-olds, over 12.5% of youth were currently using marijuana. And when we look at pre versus post commercialization and legalization, I should say, of cannabis, we see that comparing the 2 years pre-legalization and then the 2 years post-legalization, that there's a 20% increase within this age group specifically in use. Colorado is now ranked first in the U.S. for 12 to 17-year-old current use of marijuana, and that's 74% higher than the U.S. national average. And when we look at the trend over time, we see that in 2006, this age group was 14th in the nation for current use. And then in 2012, we were 4th, and now, as recently as 2014, 1st. Just kind of giving you an overview. I know this is hard to see. I'm going to kind of blow it up here in just a moment. But what we see is that there are different states listed, and this is average percent use. And then the states, blue are non-legalized medical marijuana states. Red are legalized medical marijuana states. And then green are fully legal medical marijuana, recreational marijuana that we see at the top, to no surprise, that states like Colorado, Washington, Oregon is now a green state, Alaska is now a green state, that these states with legalization of recreational use of cannabis also have some of the highest, if not the highest, right, use within youth, for which the legislation, I would argue, was not intended for. But we're still seeing growing and increasing trends. So youth cannabis use, when we really chunk the states, again, non-medical marijuana states, medical marijuana, and then legalized medical marijuana, recreational marijuana states, that when we see that 12 to 17-year-olds really clump by state, that the average percent use, right, is the highest in those states that allow for medical marijuana and recreational marijuana use, even if not for this age group. Just reiterating the point that the top states with the most amount of use, again, in 12 to 17-year-olds, are also those with legislation passed for use in adults. What we have here, the blue bars are the national average compared to the red bars, the Colorado average from 2005 up to 2014. We're looking at percent use by 12 to 17-year-olds, and what we see is that the national average certainly has varied a little bit, gone up, gone down a little bit, but overall has really hovered around kind of the same area, but that the Colorado average over time has certainly continued to increase, and that the gap between the Colorado average and the U.S. national average really continues to grow quite a bit, and certainly outpacing the nation for use here in Colorado compared to the U.S. Drug-related suspensions and expulsions are on the rise. We see that, prior to 2009, fairly consistent, fairly stable, and then certainly there's quite a bump around 2009, and that trend has varied a little bit, but certainly is up quite a bit compared to pre-commercialization levels. When we look at average drug-related suspensions and expulsions, we see that over time, again, pre-commercialization versus post-commercialization, that there has been over a third increase in the number of drug-related suspensions and expulsions. And this does include a variety of different drugs, but I should say that this data really shows that the majority of which is cannabis in this case. Total suspensions, again, same basic time frame here, looking at youth, 12 to 17. We see that alcohol violations are fairly stagnant and stable over time, but that there's a huge increase in rise around 2009, and the trend continues to go up. So we're seeing the highest levels that we've ever seen now. Looking at expulsion data, same time frame, alcohol consistent and stable for 12 to 17-year-olds compared to drug violations. Again, cannabis being the significant number contributing here, that the number is certainly on the rise again, and that there's a pretty big bump after 2009. Referrals to law enforcement, same time period. Again, just reiterating the same point. When evaluated independently, we're seeing the same trends. And again, 12 to 17-year-olds. Probation data, looking at average percent positive urine drug screens for THC, for cannabis. And then again, when we clump and look pre-commercialization versus post-commercialization, and then after legalization, that the trend continues to rise, and that the highest number certainly has been after legalization. Looking at young adults, so really college-age individuals as recently as 2014, past month use, these are 18 to 25-year-olds. We see that the national average is 19.3% compared to the Colorado average over 31%. And that very similar to the trend that we saw in youth, that when we compared pre-legalization versus post-commercialization, that there was an increase in 20% here in Colorado during that time frame compared to 20% for youth 12 to 17. Colorado is also first in the nation for past month marijuana use here in 18 to 25-year-olds, just as we saw for 12 to 17-year-olds, and that our average here is 62% higher than the U.S. national average. And that, again, the trend has really been the same over time. 2006, we were 8th, 2012, 3rd, and now 1st in the nation for past month use. Really similar graphic here, looking at college-age individuals, past month use. Blue is national average, red is Colorado average, and we see from 2005 to 2014, the U.S. national average certainly has climbed a little bit, modestly, not a whole lot. But that the Colorado average has not only continued to decline, but also significantly outpace the U.S. national average. Again, looking at non-medical marijuana states, medical marijuana states, and then medical marijuana and legalized states for recreational use, we see that clearly those with legalized status clearly outpace the rest of the nation for past month use in 18 to 25-year-olds. Same point here. Let's look a bit at cannabis-related traffic deaths. So what we have here from 2006 to 2014 are the raw number of total statewide fatalities for any cause, any reason. And what we see is that we're down more recently, not the lowest, but certainly lower than maybe we were in 2006. The reason for that, I think it's likely multifactorial, right? We have, increased enforcement, we have safer cars, with a variety of different technologies to allow for safer driving or to correct driving when the driver is either impaired or not paying attention. And then what we see, so overall, we've seen that the total raw number has gone down slightly, which is good, which is wonderful. But that when we look at over time the raw number of cannabis-related deaths, and so these are individuals who were driving and killed and had cannabis within their system, that we see that the raw number here has continued to increase. And looking at that total percentage of fatalities related to cannabis here in Colorado, we see that the overall percentage has increased from 6.92% in 2006 to over 19%, so roughly tripling in 2014. And that's just what we see here, again, is that increased trend. Again, increased trend over time when clumping pre-commercialization, post-commercialization, and then full legalization. Certainly the highest that we've seen yet is during the legalization period. Cannabis is everywhere in the media. I know that it's no news to you. We see it all over in Colorado, nationally, as well as internationally. And so, kind of taking away, what can we do with all of this use, especially where my research is focused in youth and young adults? Well, there's actually a lot that we can do. And so I wanted to highlight just one program today, and I'm happy to give you references to other programs that are out there, but this is one such program that's out of the University of Colorado. This is Encompass is the manualized treatment program, which provides for all outpatient-based treatment that's 17 weeks in duration. It can certainly be longer if needed. And it's dual diagnosis focused, meaning that we see that there's obviously highly comorbid mental health and substance use disorders that they really run together. And so we focus on both concurrently at the same time and implement and incorporate elements of cognitive behavioral therapy, as well as motivational interviewing or motivational enhancement therapy. And then contingency management, providing rewards for individuals who come to treatment, who are engaged with treatment, even if they have a positive urine drug screen, if they're still showing up, providing a modest reward for doing so. And then certainly when with increased engagement and involvement, negative urine drug screens, the rewards, the stakes become higher, right? And providing more kind of lucrative and incentivizing rewards. And then treatment certainly provided at Denver Health through the Substance Treatment Education and Prevention Program, STEP. And so I'm happy to, these slides should be available, and at the bottom I have the websites listed for both programs there. And so real quick, this is Dr. Paula Riggs, who is really the mastermind behind the Encompass program, talking about why treatment for youth and adolescents is different than adults, why it has to be different.
Working with adolescents, they often don't recognize or even feel like they have an issue with, my parents have a problem with my drug use, I don't have a problem with my drug use. It's critically important to meet the adolescent where they are in their own understanding of whether this is a problem or not. Therapists who are trained in motivational interviewing or motivational enhancement understand the techniques they need to meet the adolescent where they are and understand what their goals are. And there are particular techniques, ways of talking with adolescents that may help kind of lay out the ambivalence whether to continue to use or not and help them resolve their own and make their own decisions. At the end of the day, we know it's about a decision that the adolescent makes. It's not about the decision that the parent makes or that the therapist makes. So motivational interviewing or motivational enhancement therapy is designed to really engage with adolescents so that you could even begin treatment.
Okay, almost done. And then certainly wanting to take questions and have a nice discussion because we have enough time to. So again, summary and take-home points here. We know that cannabis, we clearly see in research and clinically as well, that it is a harmful substance that can have some pretty serious consequences, not only on the mind, but also on the body, especially in individuals whose minds and bodies are still developing, right? And we see that legalization and commercialization of really any substance certainly impacts the perception and the use by youth. And so again, a lot of unintended consequences. Prevention and education are certainly key and something that I think that we need to focus more on, but also treatment is available. So here are my references. And just wanting to acknowledge my research and clinical mentors, Dr. Christian Thurstone and Paula Riggs, whom you saw in the different videos. And then certainly happy to take any questions at this time. Here's my email address. I don't have cards today, I apologize, but certainly send me an email. I'll get back to you as soon as possible, and happy to discuss what you're seeing if you'd like to partner in any way in thinking about different prevention opportunities or any way that we could be helpful at the University of Colorado. Just send me an email, let me know. Yeah, happy to take questions. I appreciate it. Thank you so much. Yes, please.
I have two questions.
Sure.
Okay. One is about testing to find that 5 nanograms per milliliter. How are they doing that? How are they doing that for DUIs? Is actually effective?
Okay.
I know that they're using some swabs here in Denver, but just kind of the effectiveness of that.
Why don't we talk about that first, and then we can certainly take your second question. So as far as what testing options are available, in general, there's a host. You could do urine testing, you could do blood testing, you can actually take samples of hair, right, or even a swab from a tear duct at the eye and get pretty valid, important information. What's typically done in the field is a blood test. And again, that's going to be probably the most accurate and reflective of what's going on.
Is that testing like active THC, or is that if somebody smoked a week ago and it's still in their system, like how does that discriminate between I'm high now and I was high 3 days ago?
That's an excellent point as well. So it's really going to depend on the certain lab send out that is obtained. The nice thing is that we can not only look and see, are you positive, right, through qualitative testing, but quantitative testing allows us to actually look at the concentration of the active THC that's present within the blood serum of the individual. So you can do both. You can see positive or negative, and also to what degree. Your second question, please.
Prevention. What is happening? How are you using this information to put it out there to teens about what it does to their body and their brain?
So, I mean, there's a lot that's being done on the state level. But for what we're doing at the University of Colorado, we really try to engage not only individuals who've been involved with treatment for maybe some other reason. We try to educate and prevent there, but also getting out in the community and going and speaking with youth at community centers, at schools, right, different sporting events, wherever we're invited, just wanting to go and more than anything else have a conversation. So we feel that it's very important to be out and to be present within the community, and are trying to do as much as possible, and certainly would love to do more. So if you have any ideas about further partnership or ways to get out there, again, just wanting to have a discussion more than anything else. Yep. Yes, sir.
With respect to, is there much research as to the most effective ways of dealing and engaging adolescents? I mean, from what I've seen, the problems you run into is you're dealing with a population where the parents are either using or even using with the kids. You're dealing with situations where often if you have them go into some kind of treatment program, they're dealing with people with more accelerated addictions, and so instead of getting better, they actually get worse. What does the research show as to what is effective?
It's an excellent question. So number one, really what we see anecdotally, clinically, from the research is that the earlier that you can educate and prevent, the better, and then also the earlier that you can intervene for treatment, the better. We see just better outcomes there. And then also, to your point, certainly engaging family and friends who are important to this individual, who are involved in this individual's life, that we try to engage them whenever they're willing in treatment. We always, so we have a family focus component that we use within our treatment as well. And really, again, we know that, we don't live in silos and that it takes a village in many ways, right? And so really trying to engage any and all individuals within the community and especially within the household to be involved with treatment and care, to educate those individuals as well. It's not a perfect method, but it's certainly one of the best things that we have for right now.
But are there interventions that are more effective? I mean, I remember growing up watching this is your brand drug commercials, and we all used to make jokes about it. If that's the intervention, that's not often going to be effective. And And so I get that obviously early and intervention are important, but if it's not the right kind, then
Agreed.
we're not going to get anywhere. And so is there anything that can help guide us as people who are actually in the field to say, okay, this will work better than that or something?
You know, unfortunately, there's not a whole lot. There are certainly interventions out there, but as far as anything that's really a front runner that's showing really dramatic, game-changing results, I'm not seeing it right now. I apologize. We need more research. Again, we really need more. You know, ACT. It's not a prevention strategy, but it's certainly a strategy that we're taking on for treatment that we're trying to incorporate more greatly in our treatment strategy, because I think that it is much more empowering to the individual as well as families as well. But again, that's the treatment side, that's not prevention. So we certainly need more work to be done and more research. Yes, sir. Excellent question. Please.
Does the Encompass program accept Medicaid or contract with the Department of Human Services?
Yes to both. Yep. Yes, sir.
I have a couple of questions. One, the statistics you gave about fatal car crashes. It's simply saying that the driver was positive for THC in some fashion without considering other possible issues like alcohol.
And these individuals were seeing that that there were no other confounders. So it was marijuana related. We can say that it was from marijuana, not alcohol, cocaine, right?
Okay, good, thank you. And then back to one of the questions she was asking you about testing for active THC. So, and maybe I'm a little ignorant about this, but what do you mean by that?
So delta-9 tetrahydrocannabinol, the molecule that we saw, is going to be the active component. And so what we've seen is that when you have an active effect from that molecule, but that also an inactive component is stored within fat cells and then metabolized over time, so broken down to then the active component. So it can take a long time for all of the active THC to then be out of your system. How exactly that's metabolized, to what degree, what rate in different individuals, right? That's going to be different. And frankly, we don't totally understand that, which is another reason why I'm certainly advocating that we have more research, and that you could maybe make the argument that maybe legislation was put, and policy was put before the actual science, because simply we don't understand many aspects of that yet.
So the truth is, as we stand now, we can't test for that.
We can't test for.
You can't say this person is high from a test result of THC.
Oh, let me clarify. That's a wonderful point. So yes, we can absolutely test for if they are high, going through an exam, but also with a clear, concrete lab value and test, we can absolutely say this person has this much of the active component actively circulating within their system. Yes. What I'm saying is that more longitudinally, the inactive form that is stored, how exactly that will be broken down and how much active THC will be released at a certain time, we can't totally model that yet. And so we don't know how different people are going to break down that inactive form to the active component, and maybe, because it's likely not done so in a uniform fashion, meaning you can't say that this percent of the inactive form will be converted to the active form at this rate. It's going to be different for different people, and there's a host of different factors that go into that process metabolically. And so that's what I'm referring to as far as we don't know exactly how the inactive component is converted to the active component over time. We need more research there. But to answer your question, the active delta-9 THC that's present within an individual's blood and is affecting them and creating the high, as you say, yes, we can absolutely tell very concretely through a test what is that value and what is it right now.
That's the nanograms of THC in the bloodstream.
Per milliliter.
So that when it says you have 6 nanograms of THC in the bloodstream, you would say that person is impaired.
Certainly. But impairment also can be different from a policy standpoint and then from a medical standpoint. I would argue, yes, at 6 nanograms per milliliter, per a policy, per a legal standpoint, certainly. To what degree is that individual impaired from a medical standpoint? This is really where the dicey, tricky issues come in, and where the science, we still need more research, because we know, many proponents will argue, well, maybe someone at 6 nanograms is not impaired, or impaired to the same degree that someone is at a different level. And that certainly could be true, but we don't have enough data yet to say scientifically and safely what exactly that level should be across the board, as well as how it may be different for different individuals. Does that make sense? Okay. Yes, please.
Are you seeing therapeutically maybe adolescents that are using marijuana for a longer period of time and then move into harder drugs? Are you seeing that they're having a harder time kicking that addiction because of their marijuana use? Or have you
Oh.
any kind of studies?
It's something that we need to do. We're actively looking at a number of different studies looking at opiates in particular. So the question being, starting with marijuana, those individuals who start with marijuana and then maybe convert to a secondary substance, are you asking, is it harder for them to stop using the secondary substance or the marijuana, or both even?
Yeah, exactly. I mean, I run a drug court, so everyone that's in front of me has felony level charges, so they're always, it's methamphetamines or heroin, opioids, I should say. But we see a lot of them where their drug use started at 12, 13, but it wasn't with heroin
Right.
at 12 or 13. It was, a long time of marijuana, and they've used that for 10, 12 years.
Mhm.
And maybe they've only had the opioid addiction for the last 2 or 3. Have you seen therapeutically if there's anything that works better with that population or worse with that population?
That's a great question. So to answer, initially, yes, we see that it is harder for individuals who use more, and especially who use longer, and maybe even use multiple drugs, that it certainly becomes harder and harder for them to cut down use or even quit. And that makes sense physiologically too, right? Because we know that their brain reward pathways are certainly being altered, and we know that, at least from marijuana, there's certainly other pathways for other drugs, but we see that for marijuana that those pathways are being altered in normal development, but also that these individuals now, whether they were already predisposed to anxiety, depression, ADHD, right, that they likely, not all the time, but likely could be experiencing symptoms related to those issues, possibly secondary to the drug use, or maybe it was there beforehand. And in many ways, it almost doesn't matter to a certain degree, because the fact of the matter is that those issues are there. So I'm really kind of building the case and answering your question that I think that regardless exactly of the origin, that treatment then needs to become multi-directed and focused, because there are other issues likely within the home, with mental health issues, with substance use or polysubstance use, and so making sure that you have a regimen and a strategy that's going to be really addressing all of those issues at the same time is really, really important. It's not a foolproof method, but certainly I think, clearly we see in our data, as well as other research groups' data, that when you have treatment and prevention, but that is really broadly focused and really trying to tackle different aspects and different angles of a youth's life and how they're impacted, that you see better outcomes there. But certainly, yes, with more chronic use, heavier use, it does become increasingly harder to help that individual to cut down and quit. And certainly when there's polysubstance use, it becomes even more complicated. And so, Encompass, ACT, those are different strategies with some of the best data and results right now to really target substance use in particular, but also co-occurring disorders. But again, I just have to reiterate, and then I'll wrap up here with this question, is that really targeting co-occurring issues, which happens, and occurs in the vast majority of cases, that really that needs to be a focus and an emphasis. Yeah. Other questions? Yes, sir.
You mentioned your research showed that the effects of marijuana sometimes with adults will last longer.
Mm-hmm.
Will spread out over a certain time, time frame, whatever. Is that to the point of impairment?
Oh.
In regards to, ability to say drive or, things like that?
That's an excellent, yes. To answer your question quite directly, yes. It can certainly vary the degree of impairment for different individuals, but I think that that's probably where that data becomes the most profound. It's not just that there's an issue or that there's some nuisance or annoyance, right? It's that these individuals are really having trouble remembering. I mean, to the degree that they can't necessarily carry out their jobs, be as functional of a parent, right? And attend to other tasks or issues in other areas of their life. Yes, so certainly impairment is the key, and that they are impaired.
Is that kind of across the board with adults, or is it a certain kind of profile? Or?
That's where more research is needed, because we certainly need to be able to direct and say who is potentially at greater risk and why, and we don't know yet. Excellent question. Mm-hmm. Yes, sir.
What type of studies do they do to come up with 5 DUI, DWI?
So as far as what specific studies were done for this legislation, none. What were they modeled after? A lot of it came from studies that were out there that were, again, based off of alcohol. That's where a lot of research came from. And then other modeling, my understanding is that there's a fair amount of lab modeling based off of rodents or animals, right? But as far as there being really clear, consistent, heavy, really good data from humans specifically to marijuana, it's pretty limited. Yep. Yes, sir.
Doctor, to your knowledge, are there prevention programs being implemented at the elementary school level? To me, that's where you have to reach.
Yes, that's a wonderful question.
If you want to reach kids as they're growing up, you need to start very early.
There are indeed. Actually just conducted a review and analysis as far as what programs are available and which have the best data. And really, we're seeing for marijuana and other substances, the good behavior game is a prevention model that can be implemented in elementary schools that's really good and normed for elementary students. So it's really a game, but that's something that's very interactive and engaging for elementary level students, especially focused at their neurodevelopmental level and thinking about prevention strategies to make sure that they're aware on a basic level the harmful effects of substances. So that's the good behavior game. The Life Skills program is another program that we see moving more into middle school. That's a program that's a prevention strategy as well. Of course.
So there's such a wide variety of the percentage of THC that's sold in marijuana today. And one of your statistics was the drop in IQ by about 8 points when there's heavy use between 13 and 38. What constitutes heavy use?
Right. So what we'd see there with heavy use, and that does not look at potency in this case, but we would anticipate that with higher potency that the effects could be achieved through less use or that they would be more profound and heavier use. But with regard to heavy use, we're talking about use at least one time daily, if not multiple times daily, and we need to see that for several weeks at a time, typically 2 to 3 weeks consistently. With longer and more severe use, certainly we would expect potentially heavier or more severe effects, I should say. But chronicity really starts with, again, daily use, if not multiple times per day, and then for several weeks continuously. We see individuals who use multiple times a day for years. And really, thankfully, that's certainly a smaller number of individuals overall, but with regard to what exactly their impairment would be, we don't entirely understand. But we certainly want to have a better understanding, and so we're working with those individuals to do studies, but also thinking about with more chronic, heavier use too, then other factors come into play. Yeah. Yes, sir.
You had a slide which talked about the impact of THC lasting up to a month. I know you're dealing with opioid addiction, but the permanent change in brain chemistry is such that sometimes it can take a year to 3 years to change. When you use that statistic of a month, are you referring to after a month and that change is evolved to a point where the person's brain functioning is back to normal?
Oh, that's a great question. So that slide, so kind of reviewing what do we see with chronic use and then impairment in adults. So what we see is that in adults, the current literature states that a month out after being totally abstinent, that certainly that memory, cognition, executive functioning can all be impaired, varying for different individuals. And by impaired, we're seeing again that they are not able to function as greatly socially, personally, professionally, but that we're seeing that there are some individuals, and it's not exactly clear across the board who exactly this would be and why, but some individuals are impaired, but that they're not returning to baseline level of functioning either. And so how long could that be? I think it depends. That's a tough question to answer right now. We need more research. The reality too is that we're seeing that potentially up to years, maybe not in the same fashion as with opiates, but that there are a small group of individuals who are using very heavily, very chronically, right, and also using higher potency mechanisms of cannabis that they could be impaired, yes, for maybe even around a year or so. But certainly more data is needed. Yep. Mm-hmm. Thank you. Other questions, thoughts, comments?
Is all of this research being mirrored by other research being done, or is there some research that's stating some pretty different facts, legitimate research?
That's an excellent question. Other facts pertaining to, is there anything in particular
Just
that?
the lasting, negative effects of marijuana use, probably more so in the adult range, because that's what you hear a lot of, but it's not. You get a lot of that amongst the community about, it just doesn't.
We do see some varying research where maybe adults are not as greatly impacted. The thing that's really important to remember, though, with research is that if we're going to do something more like a meta-analysis looking more broadly, that we need to control for a variety of different factors, making sure that socioeconomically that's controlled for and that they're similar across groups. Age, gender, right? But also the type of use needs to be controlled for. And so to answer your questions, we do see some variability as far as results and data go, some of which I think is just naturally occurring variability. And so am I saying that every single person who uses heavily will have this impairment no matter what? No, certainly not. But I'm saying it's certainly a risk and a potential outcome. But again, we have not been able to standardize a norm per the current studies all of these different variables and factors to say definitively beyond a shadow of a doubt, for example, if you are a 38-year-old Caucasian female and you use this much, this frequently at this potency that you will or will not have a certain impairment, and for how long, we can't say that yet. It certainly needs to be done, but an excellent question. Yep. All right, I guess we can wrap up now. If you have any questions that you'd like to come up and discuss or anything else, I'm definitely going to be here for a bit. So thank you so much for your time. I really appreciate you coming. Thank you.